it wouldn't be so scary, and we'd be able to bring this out of a place of legitimate research. So I am a patient, I'm also a researcher, and I'm also a social worker. So I thought that that also could kind of give me a unique perspective into some of the social support benefits that go on at facilities. So I'm going to talk a bit about my study. And I'm going to give just a quick, a lot of you guys probably already know all this, but just a bit about the facility history, the medical cannabis facilities. And I use facility and dispensary interchangeably, and there's a reason for that. I did some pre-testing with the surveys I did for my study, and some of the feedback that I got was that some of the facilities, dispensaries, prefer to be called facilities because dispensary might lead to some incriminating activity. So I use facility in my research report, but I mean the same thing. So what was going on in Dennis Peron's home was really more of the social model. Lester Grinspoon kind of coined these terms of the social model and the pharmacy model, medical cannabis dispensary. And the social club model is pretty much what it sounds like. It's really not just about the dispensing of medication, but it's about the social support, and it's about addressing not only the medical needs of patients, but the social and emotional needs of patients as well. And this is kind of on the other end of the spectrum from the pharmacy model, which is how the medical cannabis system is carried out in Amsterdam, which is really more of a Walgreens-style pharmacy. You walk in, you get your medication, and you leave. Not the coffee shops, but the medical cannabis dispensing itself. And some people do prefer this, so I think that it's important to study both types of facilities and kind of figure out what's working and what's not so that we can kind of offer both types to patients. The rules, as you know, vary from city to city. As in the Bay Area, as far as medical cannabis facilities. The three cities in the Bay Area that I was kind of focusing on were Oakland, Berkeley, and San Francisco, although my study sites were both all in Berkeley and San Francisco. And then there's also a question of what's going on in unincorporated areas. They also don't really know what to do. And something that I was noticing was that there were a lot of moratoriums being issued in unincorporated areas around the development of medical cannabis dispensaries. And I felt that one of those reasons was because they didn't really know what to do. And it wasn't that they were against it necessarily or for it necessarily, but they had a lot of questions, and they really didn't know how this was going to fit into their landscape. They were afraid of making bad decisions. And again, this is one of the reasons I felt this study was important, because it gives people something to look at. And I also noticed that a lot of the debate around medical cannabis facilities was about the zoning. And is it this close to a school? And can people smoke outside? And should we have parking? And do they need this license or that license? And what was kind of being left out of the discussion was, what do the patients want? You know, when you start any new business or even a medical health service, you want to know who your patients are. Who are you serving? What do they like? What do they want? What works best for them? And this was kind of being left out of the discussions that were going on in City Hall, which is another reason I thought it was important to do this study. So my study was both a description of medical cannabis patients and a description of facilities. So I had a patient-based evaluation of services at 7 different facilities and also a description of the service utilization patterns of the facilities. The description of medical cannabis patients, I looked at, and this was 130 anonymous surveys, and God bless them, each one was 20 pages long, and they were really hard to get through. But you know, I was sitting in these facilities for 7-8 hours at a time, and we had a good time and made a day of it, so it was a great experience. So I was looking at demographics like gender, ethnicity, and income, whether or not patients had health insurance, the length of time of their symptoms, and how long they've been treated. I had a measure of general health status that covered physical, emotional, and general health. And then I also looked at 2 issues, one of self-medication and the other of substitution. There's been some really interesting work by Dr. McArea around substituting cannabis for alcohol, also for other drugs, and also the presence of self-medication. You know, we've kind of talked about the spectrum of what is medical, what is not medical, and if I take an aspirin and I just go decide to take that aspirin, is that self-medication? Well, of course it is. I decided to do it. If I will have a cup of coffee in the morning, I don't need a doctor's prescription to do so. I've decided to do it, and that's self-medication as well. So that was another concept that I was interested in. And then I also had an alcohol treatment component, and the reason I did this was because I noticed there were a lot of similarities between 12-step programs and the social model of medical cannabis clubs, and that there really wasn't an expert on hand. Like, there's nobody in the club with like a white coat who's standing there, you know, with some kind of stethoscope to administer your medication. The people that work there mostly are patients. They are people that can relate very well to the people that they're serving. That was where the alcohol interest came from. So I wanted to know if medical cannabis patients had been previously in alcohol treatment. If they have, is it their choice to go? And then their satisfaction with various types of alcohol treatment. So we could maybe look at some commonalities between alcohol treatment models such as 12-step versus like a hospital inpatient program, and different dispensary models like the social club model versus the pharmacy model. So besides the 130 patient surveys, I also collected 7 manager surveys from each of the 7 facilities where I did my research, because I wanted to know a lot about the environmental characteristics. Because if we know a lot about the patients and what they want, we also need to know what's going on in the building and what the experiences are of the managers so that we can develop good services. So I asked the managers about how long they've been in service, their hours, square footage, what the ID requirements were to enter, rules and regulations in the facility, the staff makeup, so do they have counselors on staff, do they employ legal counsel, security, what products are offered, and this includes cannabis and non-cannabis products, what services are offered besides the distribution of cannabis, and what the reported political and legal relationship has been like with the medical cannabis facilities and local government and police. So the patient-based evaluation of services, I really just wanted to know how satisfied patients were with the services they were receiving at the facilities. And these were across 4 different dimensions: general satisfaction, access, interpersonal, and privacy. I used a standardized test in order to gather this. Privacy I added on my own. And then service utilization. After I went to each facility and had managers fill out surveys and tell me what services they offered, I then developed site-specific patient surveys so that when I went back to the facility to give the patient survey, they were only asked about services that that facility offered. That way I figured it wouldn't be as confusing. And I wanted to look at the social model and the wide variety of services that are offered. So my methods, this is a little sciencey and I apologize. It was exploratory cross-sectional survey design. I had 130 patient surveys at 7 study sites, 2 in Berkeley and 5 in San Francisco. I had the facility level and patient level data. I collected the data myself. All surveys were anonymous, and I had people fill out surveys at the facilities themselves so that they could capture the satisfaction. The measures I used, I designed my own survey. I also had 2 standardized pieces. I used the RAND 36-item health survey in order to capture health status, and the patient satisfaction questionnaire 3 in order to capture satisfaction data. So how did I go about collecting this? Well, I basically just went to a facility. I got a list off the internet from the California Normal website, and I identified a few in several areas of San Francisco because I wanted to cover. And I just went and I bought my little Berkeley business cards and my little human subjects has approved this study form, and I just asked them if they wanted to participate. And I said they'd be completely anonymous, all patients would be completely anonymous, and then I explained the purpose. And that I really wanted to take what was going on here and start publishing it in social work journals and in public health journals and in public policy journals. And I wanted people from other states to be able to read this information and to use this information. And people were really, for the most part, very supportive. I sampled from inside the facility. Some surveys were self-administered. However, if there was a vision problem or a literacy problem, I administered the survey. And I just asked everyone that came in if they wanted to participate, and I stayed at each place for about 4 hours or so, and then I would just visit them at various times during the week. So, okay. I'm going to go through my results, because that's probably what you guys want to see. So first I'm going to talk about patient satisfaction, and I think that this is really important. As some of my other activist friends have told me, this is what's going to be the soundbite. I don't have on here the comparison data, but the sample of 2,000 medical patients that the patient satisfaction questionnaire was normed on, meaning that they gave it to 2,000 people to see what the general feeling of satisfaction was in the country around medical services, and it's significantly lower than the satisfaction reported by medical cannabis patients. The scores, if one is a perfect score for satisfaction for medical cannabis patients, ranged from 0.77 to 0.87, and for the national average is 0.5 to 0.65. So I think that that's showing that, in addition to just dispensing cannabis, there's something going on that patients are really responding to. And this is on the privacy scale. And then another question I thought was important to ask was, why did you choose this particular facility today? Because I think it's important to know that what patients deem important when choosing what facility to go to. So I had all these different reasons, and then they